Hello everyone. So today we'll talk about JVP. And trust me, JVP is the most important topic in whole medicine. ये आपको एमबीबीएस टाइम पे काम आएगा. आगे आप एमडी मेडिसिन पीडियाट्रिक्स करते हो तो आपको काम आएगा. एंड इवन इफ यू विल बी डूइंग डीएम कार्डियोलॉजी आगे, then it will help you a lot. And not only academically, as far as patients are concerned, it is the most important thing to see in a patient. And in NEET PG also there are a lot of questions on JVP as well. So this video is particularly for people who are preparing for NEET PG, as well as for the students who are going to give their final year MBBS medicine viva, or for the people who are also about to give their MD medicine practical exams. So coming on to how to assess JVP first. So आजकल नीट पीजी में there is a trend कि वो ऐसे clinical questions are frequently being asked. So there can be a question like which of the following is not true about how to assess the JVP. Now what you have to do is you have to make the patient lie at a 45-degree angle. That is very important thing. Make the patient turn head to the left. Shine light diagonally at the neck region and then see the height of the JVP. You have to see the height, one thing, and you have to see the waves also. Now, height maybe you have to see the maximum height. Just point pick. Suppose two waves are there in a JVP, two upward waves are there in a JVP. So upwards दोनों wave में भी जो सबसे highest है is the maximum height of JVP. Okay. Now, after making the patients lie and pointing the light diagonally at that point of time, you have to see the JVP waves. So first thing is you have to differentiate between a JVP and a carotid pulse. So how you can differentiate between a JVP and a carotid pulse is in JVP there will be two pulses per heartbeat because there are two positive waves. And another thing is JVP is better seen than palpable because it's a venous pulse. So if you have like confusion that whether it is a carotid wave or it's a JVP, you can just palpate it. If it is not palpable properly, then it is a JVP. If it is palpable very nicely, then it is a carotid wave. Okay. And another thing is what is the position? So it is generally looked after just behind the sternocleidomastoid muscle. Now, what to do? You have made the patient lie at a 45-degree angle. Then you have to measure the height of the JVP. For that, you have to take two scales and then put them perpendicularly. Like one scale is like this and another scale is like this. And then you have to measure the height of the JVP at that point of time at the level of angle of Lewis. So you have to measure at the sternal angle. So suppose the at the sternal angle, this height is coming 4 centimeter. So your total height of the JVP would be 4 plus 5 because the RA and the distance between RA and sternal angle is 5. So the total height would be 5 plus 4, that is 9. So how to say whether the JVP is elevated or not? So if at the sternal angle JVP is more than 3, then it is elevated. Or agar if you will add 5 in it, so if it is more than 8, then the JVP would be elevated. So summarizing what I have discussed till now, you have to make the patient lie at 45-degree. You have to see the highest point of the JVP. You have to take two scales and then measure the perpendicular height at the angle of Louis. And then you have to add 5 in it. So after adding 5, if the total height is more than 8, then it is a raised JVP. And before adding 5, if it is more than 3, then it is a raised JVP. Now, after visualizing JVP, you have to focus on the waves as well. So coming on to what are the waves in a JVP? So there are two positive waves, that is a A wave and a V wave. Then there are two descents, that is X descent and a Y descent. And there is a notch, that is a C wave. Now, why these waves are coming is another questions that are being asked. And also you have to know in a normal condition which wave is bigger. So in a normal condition, A wave is bigger than a V wave and X descent is bigger than a Y descent. Okay. Now A wave is because of the atrial contraction. So when the atria contracts and pushes the blood into the RV, then it is a A wave. After A wave, we have a X descent because now the blood is pushed into the RV, so the pressure of the RA start decreasing. So we have a X descent. Now, when there is a X descent and the pressure in RA keeps on decreasing, there is closure of the mitral and tricuspid valve. So due to the closure of the tricuspid valve and upward movement of the tricuspid valve into the RA, there is slight increase in the pressure at that point of time. leading to a C notch. Then we have V wave. So V wave is because of passive filling of the RA. And there is Y descent again because of the filling of RV blood from the RA. Okay. So we have two waves, upward waves, two descents, and a notch. Now, if we correlate these with the heart sounds and ECG, so these type of questions are nowadays asked. You have to, it's very simple if they will ask you why a wave comes or a why C waves comes. But the important concept lies in the fact that you have to correlate the JVP with the heart sounds and as well as the ECG. So first of all, you have to understand that anything would come first in a ECG because it's an electrical thing, and then it would be converted to a mechanical thing. So anything would come first in a ECG, then it will be reflected in the myocardium. So there would be ventricular depolarization first, then there would be a ventricular systole. Okay. Now coming on to this part. So at A wave, there is contraction of the atria, followed by a C wave. तो सी नॉच में क्या हो रहा है देर इज क्लोजर ऑफ द ट्राइकस्पिड वॉल और उसकी वजह से देर इज नॉचिंग ऑफ द ट्राइकस्पिड वॉल इनटू द राइट एट्रियम तो क्लोजर ऑफ द ट्राइकस्पिड वॉल is producing a sound that is S1. So first there would be S1 and then there would be a C wave. And S1 से पहले क्या आएगा electrical changes that is QRS. So there would be a ventricular depolarization first. So you can see here there is a QRS complex सबसे नीचे उसकी वजह से there would be a S wave after that and then there would be a C notch. So if you will correlate it there would be QRS then S, then C wave. And all these will occur in a same line, like QRS, S, and C. And the QRS complex would like correlate with the X descent. So the QRS complex would correlate with X descent, followed by a S1 and a C wave. Similarly, when there is ventricular repolarization, that is marked by the end of the T wave. So when there is ventricular repolarization, at the end of T wave, there would be a S2. So end of T wave followed by S2, followed by peak of V wave. Okay. So you have to know this relation between a JVP, heart sounds, and ECG. So the sequence would be QRS, S1, C, and in repolarization part, the sequence would be T, S2, and V. So between S1 and S2, we know there is a systole. So in JVP, between X descent and on the Y ascent, there would be a systole and the rest part is diastole. Okay. Now coming on to the abnormalities in JVP. These are again frequently asked questions. So first is absent AVIM. It's a very conceptual thing that whenever there is atrial fibrillation, there won't be any contraction of the atria. So there would be absent AVIMs. Sometimes in so much of sinus tachycardia, the atrial contraction won't be visible on a JVP and then it can also lead to absent AVIM. But the most important thing that you have to remember here is atrial fibrillation. Then there can be flutter wave seen, that is multiple A waves seen in JVP that can be seen in atrial flutter. Then prominent A waves can be seen in first degree AV block. Large A waves, large A waves is because of when there is obstruction to the atria contraction, which can be seen in tricuspid stenosis, right atrial myxoma, pulmonary hypertension, and pulmonary stenosis. Canon A waves are again very important and frequently asked questions. Canon A waves कब आएंगे? जब atria contract करेगा against a closed tricuspid wall. Suppose the tricuspid valve is closed and the atria is contracting. There would be a very large A wave, and that is called as Canon A waves, and it is seen in cases of AV dissociation. And AV dissociation can be because of ventricular tachycardia as well as junctional tachycardia. Then there would be absence X descent in tricuspid regurgitation. Prominent X descent is seen in one thing is cardiac tamponade, another thing is any condition which causes enlarged A wave. Okay, because A wave is followed by a X descent. So any condition in which there is a large A wave, there has to be a prominent X descent. Then there would be large CV waves in cases of constrictive pericarditis and tricuspid regurgitation. Again, an important question. Slow Y descent in tricuspid stenosis and right atrial myxoma. Rapid Y descent, very important question. And mostly the option that they want you to know is constrictive pericarditis. And it can also be seen in tricuspid regurgitation, severe right heart failure, and atrial septum defect. But if you want to remember one, the most important is constrictive pericarditis. Absent Y descent is seen in cardiac tamponade. Again, a very important question. अब theoretical part तो you know now, and theoretical part is being asked from many years, and questions never change but the way of asking changes. तो अभी क्या हो गया कि they now give you the wave and they just ask you कि in which condition this type of wave can be seen. So you have to identify the JVP wave and the condition associated with it. So अगर I'll try to describe between constrictive pericarditis and tamponade because these are the most frequently asked waves. So you can see that the normal JVP looks like the first image. It is a A wave, X descent, V wave, Y descent, and a C notch in between. And out of this, A wave is more prominent than a V wave, and a X descent is more prominent than the Y descent. Now, in cardiac tamponade, you can see there is a prominent X descent, while the Y descent is absent. You can see that the flattened Y wave. So this is the JVP of tamponade. You have to see it, you have to identify it very carefully. Then in constrictive pericarditis, again, you can see there is a prominent Y descent. And due to this prominent Y descent, now in constrictive pericarditis, the Y descent would be more prominent than X descent. And due to this, it looks like a W pattern. So it is also known as W pattern of JVP in constrictive pericarditis. So you have to see them carefully because they can be asked in the examination. Now, I want to show some other images of the JVP. So few of them are important. I will focus on that only. First, you have to focus on the A wave, A image, that is tricuspid regurgitation. So here you can see there is no X descent, directly a CV wave is there. So after C notch, there is a V wave. So the CV waves are seen in tricuspid regurgitation. You see them carefully and try to identify them. In the C image, you can see in constrictive pericarditis, as we have already discussed, there is a prominent Y descent and a W pattern is seen. In E image, you can see there is atrial fibrillation, so A waves are absent. Coming on to the B image, that is tricuspid stenosis, you can see the A wave is more prominent. So A wave, prominent A waves in tricuspid stenosis. And focus on the G image. It is really important and has been asked multiple times. You can see all waves are small, and in between there are very, very tall A waves, that is Canon A waves, and it is seen in complete AV block ventricular tachycardias or junction tachycardias. So that's all about JVP from my side. I'll try to summarize it for the people who are going to give their clinical exams as well as for the people who are about to give their entrance exams. So try to remember it, and if you have any doubt, just let me know in the comment section. All the best.